Hi, everybody. Welcome to the Arkansas chapter of the American Academy of Pediatrics podcast. We are just a few episodes in, so excited to have this new way to communicate with our members and our friends across the state of Arkansas and beyond. We are glad to be here today with Dr. Camille Broussard. You all may remember her name. She spoke at our conference. It was our keynote speaker last year at our annual education conference, where she spoke on trauma-informed care, relational health, and resilience-based approaches for adolescents experiencing adversity. I've heard so many good things about your presentation last year, Dr. Broussard, and we're so excited to welcome you back to our podcast this year.
Awesome. Thank you for having me, and thank you for the opportunity to speak with everybody on the podcast. I think I can introduce myself now. Um,
Perfect. Yeah.
so, as we talked about, I am an assistant professor of pediatrics at Johns Hopkins University currently right now. I'm a specialist in adolescent medicine as well as addiction medicine, and was originally trained in general pediatrics. So I provide just primary and subspecialty care to adolescents and young adults. And really sort of my focus has been on educating all levels of trainees, as well as continuing medical education on trauma-informed care, structural competency, and relational health. So this is sort of right up my alley, and something that I really enjoyed was giving the keynote speaking last year.
We had such a good time, and you spoke on some tough topics. And I think, here in Arkansas, we are one of the states that has one of the highest rates of childhood adversity here in Arkansas. And I think that, a lot of our practitioners are still, like many pediatricians across the country, are still learning what is trauma-informed care. I wondered if you could get us started by just taking a few minutes to explain your definition of trauma-informed care and what that means in a pediatric setting.
Absolutely. Thanks for asking that question. So, I think the most important part to remember for pediatrics is really that trauma informed care is relational health. And so, what I mean about relational health, it really means we're talking about how do we support children in having safe, stable, and nurturing relationships. And that should be ideally with their primary caregiver. And so, part of trauma informed care is being able to kind of recognize that trauma does affect health, especially in pediatrics. And so once we sort of realize that, we want to recognize the symptoms, and then we want to put that all into practice so that we're coming from this from a lens that's really empathetic and understanding and encouraging those relationships to build better health. So I think in pediatrics, it's a little bit different because we're not looking at just one person. We're really looking at the family unit, but also looking at the community unit as well. And so I think that when I talk about trauma informed care, I'm really saying that I can recognize that trauma affects people, especially adolescents and little babies and school age kids. And that what I need to do is be mindful that trauma is ubiquitous, like you said, and it occurs across all demographics. And so if I come to that with that understanding, then I'm able to kind of have this really great relationship with my patients and their families to help them understand how things outside the office are impacting their health.
That's lovely. And my background is in public health, and it feels so much and so much like just talking about what public health is, right? It says that the things that happen maybe outside of your control or in your community or in the world around you impact who you are and how you see the world and how you're able to function as a human in our society and our community. And it's a really, yeah. Thank you for sharing that definition.
Yeah,
I'd,
and
I'd love for
I do
uh,
think also, if I can just add really
please.
quickly, I think the other thing that is really cool about pediatrics is we really take a life course perspective, right? We may have the opportunity to see a sort of a preconception visit and then actually see a child born and then follow them through sort of all of the learning, all of developmental stages. But really, if you think about that from this life course perspective that is embedded in public health, as you said, we really can start to make differences within our families and our communities.
Love it. I love it. And I think you brought up the word empathy or empathetic in talking about the way this works. And I think pediatricians, by their nature, I mean, but you went into pediatrics, so clearly you care about helping others and about feeling and understanding some of the things families are going through in order to help them through it. And could you talk a little bit about that role of empathy? And the first, like, real question I have is like, how do pediatricians protect themselves as they start to think about incorporating trauma-informed care principles into their practices.
Absolutely. So I think the important thing to remember about empathy is that we should come to our visits with an empathetic lens and not a sympathy lens.
Mhm.
And I think that's a really important distinction, because empathy is basically being able to say that you're listening and you're there and you're supporting versus feeling sort of sorry for someone, which is more of the sympathy. And so when you come to this with a empathetic lens, you're actually trying to understand that there's something that might have happened in this patient's life or to this patient instead of like what's wrong with them and I just need to fix them. And I think that that's where empathy comes into play with our practice, and really helps us develop this really amazing sort of patient provider or family provider relationship that then just builds. And once those families and those patients feel that empathy, they feel safe to disclose more and more. And then you start to really benefit from that relationship and understanding, oh, I get this family now. And this is what it means to really move health forward in a very different way than like, I can diagnose asthma, right? I can diagnose a sinus infection. I can prescribe medication and antibiotics. But this is a different type of prescription. This is really a prescription for healthy relationships in a child's life. And part of that is your own relationship and making sure that that's an empathetic and authentic one. And I think you bring up a really good point is this is hard work and it's very emotional and it can be emotional. And so part of that is like, how do we protect ourselves as providers from secondary burnout or secondary trauma? Because it is real, right? I think the one thing that I always count on is having someone that I trust within sort of my peer group or my, group practice or, somebody that I can sort of debrief with, kind of be grateful for the experience that I am having with a particular family, but then being able to kind of talk to someone about, hey, this is really heavy. This is what I found out today. And I just really need someone to listen or help me process this experience. And a lot of times when group practices or even academic centers implement trauma informed care, it's got to be almost like a culture shift, right?
Mhm.
Because you really need the supports and structure for providers to feel safe to say, you know what, we are dealing with some heavy things and challenging situations. And we want to support our providers so that they don't become burnt out and then more reluctant, right? Because that's what happens. You become then reluctant to ask those really deep questions.
Right. Right. And I think, your point about like that you're grateful for the time that you've spent with a patient and all, I mean, but sometimes when that 15-minute visit devolves into an hour of talking about all of the deep and traumatic things that have happened in a family's life over the course of that visit, and you come out of there and it's been an hour, and you have to kind of take a breath before you walk into the next room with a refreshed, good morning, how are you today? Sorry, we've been waiting for a little while for me. That can be hard to do, and figuring out how to build the right team in your practice and afford to build the right team in your practice, so that you can share some of that privilege and the harder times too. Um, I know a lot of our pediatricians here in Arkansas are in privately employed practices. As they think about, beginning to ask some of these questions that we'll talk about a little more in a few minutes, but like as they begin to start thinking about that, who else do you think needs to be part of that team, ideally, either within their office or as a referral partner or somebody, outside that they can have as part of their arsenal of helpers and supporters for families?
Absolutely. Thanks for that question. That's a great question. And something I think we think about a lot, especially with the trauma informed care, because as amazing and superpower, that pediatricians have, we can't do it by ourselves. And I often will actually tell that to families and patients is like, I'm super grateful and honored that you would share this with me, but I also need my helpers and my experts in other fields, right?
Mhm.
I think one of the big ones would be social work or a case manager, right? Somebody that can spend maybe a little bit different type of time with your patient or your family to help with those resources, to help finding connections to community providers or grassroots organizations. Um, and to have those follow-up visits that you may not be able to schedule as frequently, just given real
Right.
life like insurance and practice limitations, right? Um, and I think if not a social worker, I also think that having sort of a psychology reference or resource or referral would also be really helpful because, and it doesn't have to be in person. I think a lot of what we've learned from the pandemic is we can do some of this via telehealth. And so
Mm.
even if you kind of have a little referral network that you're like, you know what, I know an awesome psychologist that is trauma informed, gets my patient population, and you are able to utilize that so that you are also not being the therapist when they come back for appointments. You're there to listen, you're there to try to strategize and prioritize and triage, but you're also there to help, kind of put them in contact with somebody that can provide that therapeutic work that they might need, or even having someone that can work on that patient caregiver relationship, right? And nurture that relationship and make that sort of a better and more positive experience. So I think those were probably the two that I would say would be the most important. I think when we're always talking about sort of these conversations, people get scared about the social work, right? Because we have sometimes a negative connotation of who a social worker is, like, oh, is this going to lead to child protective services being involved? What does this mean? Is my child going to be removed? So I often, before I introduce my social worker, will kind of preface with, this is my team member, and this is my expert that helps me with connecting you to things that you need. And I think when you introduce a social worker like that, you get more buy-in from the family, knowing that this is not about just reporting and sort of like getting this sort of like punishment type of referral. This is really about supporting and nurturing essentially. So those were the two that I would give.
I love that. I want to put a pin in the conversation about healthy steps because I would love to circle back on that, just thinking about those extra team members in Arkansas. But one other thing about the pediatricians, I wondered if you could talk a little bit about considering bringing in team members. We are still working on diversity in medicine, I think very broadly, and diversity in pediatrics, and making sure that we have teams that reflect the patient population that we serve. Can you talk a little bit about what that might mean in a pediatric practice, to think about that as part of who is on your team, about reflecting the patient population you serve?
No, that's a great point. I think it's very important. And it's something that we talk about even within pediatrics, right? Is like workforce diversity and making sure that it reflects the population that you serve. And a lot of times that can be hard to find. But I think that the effort and the investment in that is going to go a long way with patient populations that have been historically sort of discriminated against or marginalized or oppressed, right? And so if we work on sort of making sure that we have a really diverse pool of workforce to help support our families, or even community organizations that we're linking to that have that particular interest, like, this is who I'm working on supporting. I think that's really important and something that goes a long way with our patients, to feel comfortable and build trust and feel like, what you understand, what I'm trying to go through and how I need to get better.
That's beautifully said. I love it. Um, I'd love for you to talk a little bit about some of those top tips you would have for a pediatrician. So, let's imagine that we have a pediatrician who is on their own in a practice of five or six pediatricians, which is kind of the average clinic size here in Arkansas, give or take. Um, let's say that they didn't learn about this during med school or residency. This is their first entree into this today on our podcast. What are the top few tips you would provide to them as they start to get to work on incorporating trauma-informed care methodologies and principles into their practice?
Now, that's a great question. And I think it can feel overwhelming right at first when you're dipping your toes into something new and you're like, oh my gosh, I have 15 minutes to do this. How do I do this? I think not worrying about sort of doing these extensive evaluations or like really long screeners, and actually just asking one or two open-ended questions. And I think my favorite is just like, since your last visit, has anything scary, upsetting, or stressful happened to you, anyone in your family, or anyone close to you? And that tells you so much information without having to like say like, what specific trauma have you experienced, since our last time? It opens the door to so much information and to like actual listening, and genuine interest in understanding the patient. So I think that's my number one tip. is
It
just
kind of lets the patient lead that and tell you as much or as little as they want rather than asking that very specific, have you experienced A, B, or C, right?
exactly. And I think what I tell pediatricians all the time too is like, we're just remember disclosure is not the goal, right? The goal is just for people to feel comfortable with you, knowing that you're a safe person, that in the event something does happen, even if the answer is no today, or maybe I don't feel comfortable, right? My first time meeting you, you've asked the question. So now they know that you're interested in understanding their life a little bit better, other than just, what are your symptoms of asthma and, how many times are you coughing at night? And those, very sort of medical school things that we learn. So I think my top tip is asking that just really quick. It takes 2 seconds to ask that question, listening and then reflecting back on that question. Even if you don't have time to, sort of fully delve into that, you can acknowledge that and say, you know what, I feel really honored, or I feel really grateful that you felt comfortable sharing this with me. I don't want to ignore this. I think this is super important. I unfortunately don't have all the time in the world today to address this, but I want to make sure that we put a pin in this and come back for a follow-up. And so that makes it feel way more manageable, so that you're not like, oh my gosh, I have to spend 2 hours with this patient unpacking every single thing, right?
Right. Right.
So I think that's my number one tip. My second tip is probably, we've all got those patients on our schedule that we're like, oh my gosh, this is a really difficult or challenging patient, right? And you can I'm sure right now as you're listening, you can literally name that person or name that patient's family. And you're like, oh my gosh, I have to book this patient for so longer because, it's going to be complicated.
Right.
I think what I try to tell pediatricians is to try to reframe that instead of saying, like, what's wrong with you or what's difficult about you or this relationship, and think about, well, what has happened to you, so that how are you presenting to clinic? Maybe, you're getting that side of someone that's defensive in clinic because something has happened and they've had a bad experience. So I think that that's not really a question you ask. It's just more so in your head of how you are interacting with the family.
Right.
And then I think the other thing that is a little bit easier to do and doesn't have to take up a whole lot of time is start to recognize what strengths your patient and your family has and the community has, right? Because the best way to sort of mitigate this risk and adversity is really building upon those strengths and supporting and building up that patient sort of caregiver relationship. So start to kind of recognize, right? Like, I always ask my adolescents, like, what would your best friends say about you? Or like, what adjective would your best friend describe you, right? And they always say something like, oh, I'm super funny. I'm like, I think that's great, right? And so you use that knowledge, maybe not today in that visit, but maybe next time.
Right.
And you use that to your advantage to understand how you can sort of help that patient get through what they've gone through. So I know it seems daunting a lot of times to be like, oh my gosh, somebody disclosed something really scary or very, heavy or very deep. But I
Mhm.
think when you break it down to what is that experience like? How can I build on your strengths to help you? And how can I support that caregiver relationship? I think that those are the things that make the most sense long term. Um, and I think it's a good way of triaging a very complicated situation in a very short amount of time.
Yeah. That's beautiful, and I think it gives you those tips to, like, be able to get in and then back out of the exam room, but also to acknowledge and build that relationship. So check in, open-ended questions, right? That
Yep.
open-ended question, "Has anything scary happened to you?" Reframing that back to them, talking about you also talked a little bit about that reframing, like, the non-compliant patient, if I can use that word, into, what happened to you. And then lastly, kind of that strengthening that strength space and the family. I love that. I love
Yeah, I
that.
think those are like how you get around, working this in a very busy or, sort of time sensitive or time crunch. I think also what patients and families, in my experience, appreciate is honesty. So if you really only have 10 or 15 minutes, being upfront with that, right? So because the worst thing is when they feel rushed. So they've just disclosed, right, that they had this horrible event happen to them, and then you completely don't even acknowledge it. You don't summarize it, you don't
Right.
acknowledge it, and you're like, so back to your asthma, or back to why you came here today. I think what I have found is the more I'm honest and more transparent with my families, to be like, I really appreciate you disclosing this, and I wish I had time today. I don't want to ignore this, but I do have to kind of end this visit within the next 5 to 10 minutes.
Right.
Letting them know and cueing them that you care, you listen, you heard them, and
Yep.
you're going to make a plan. And it's usually just follow up.
Yeah. And you know what's really funny? I was just thinking about this as a patient and as a mom who makes appointments for my kids. Like you call and you make an appointment. You don't know how long is the appointment for. I have no idea how long I'm on the schedule for. Is it 5 minutes? Is it 30 minutes? I don't know. So I think that's a really neat way of kind of helping families have a better expectation about what to expect in their healthcare visit too. Like right from the get-go, say like, our well child visit this morning, we're going to talk about a lot of different things, and we have about 15 or 20 minutes to accomplish this visit or whatever you might say to kind of set that family's expectation. Love all that. As you were talking, it made me think a little bit about how I, as a mom of, I have a toddler and a school age kid right now, how that might be different for me depending on which kid I had with me, and how you engaged with my toddler might be very different from, which might be mostly with me, might be very different than how you would engage with me as mom of a school age kid who can have a thoughtful and, interesting conversation with you. And then as with an adolescent who may even be there on their own, or having, it was transitioning into those times where they have the one-on-one time with you. Talk a little bit about how trauma-informed care principles kind of work with each of those different groups of patients for me, if you will.
Yeah, absolutely. So I think when we start with the youngest group, right, the infants and toddlers, they are pretty much solely reliant on some sort of caregiver, right?
Right.
So they can't get around by themselves. They're relying on shelter, food, security, safety, all of that. So a lot of times when I think about trauma-informed care for those youngest, I'm really thinking about building that really initial relationship and then observing that relationship. So I'm kind of making these mental notes or these mental cues of like, okay, you know what? Maybe discipline or sleep is the issue today, right? And maybe it's related to some sort of stressful event that's going on. And so I'm sort of making sure that I'm also assessing the caregiver. And I think that sometimes we're a little bit scared to dip into that world of like, but the caregiver's not my patient, right? But they kind of are, especially in pediatrics. So sometimes when I recognize something is a little bit off, I will just acknowledge, you know what? Many times there's a lot of stress in families and life events. I just want to know, like, how are you doing today? Is there anything that you want to share that might be helpful to understanding this picture? So I really do focus a lot on the caregiver, and then like setting good expectations about like behavior and developmentally appropriate things, right? And so I think that I focus mainly on the caregiver. And then when you kind of jump to like the school age kids, this is where they're able to a little bit express more, right? So you may have like more somatic complaints that they talk about, right? This may be where like belly pain comes into, right? Or headaches, or maybe even just like new bedwetting, like all of a sudden, right? And so there's some somatic complaints that can kind of more so come out around this sort of school age time. So at that point, that's also where I start to talk to the school age child about their feelings and how the mind and the body are all connected, and start to really help them also understand what's happening. And so I'm still doing the same stuff with like caregivers and making sure I support that relationship. But, if their tummy is hurting them, I break it down into really developmentally appropriate language. Like, that feeling of like butterflies in your stomach, sometimes that happens when we're stressed and, when we might be hurting. And so I think that you can start to infuse more sort of developmentally appropriate language during that school age period. And then when we get to my favorite age group here, the adolescents and young adults, they may, yeah, absolutely. They may come to the office by themselves. So that's a very different interaction, because you may not be able to assess if there is any caregiver,
Right.
conflict, right? And so sometimes, I will talk to them about what's going on at home or what's going on at school and trying to figure out what's going on. But I would say don't ignore the caregivers for the adolescents and young adults. They are still super important. Even if you've got a young adult that's in college, a lot of times they're still relying on their caregivers. And so I still do, even when there's high conflict, I still make sure that the parent knows that there needs to be structure, there needs to be routine, there needs to be that caring, nurturing relationship, because their brain is still, developing and needs that sort of safe, stable, and nurturing relationship. So it looks a little bit different because you're talking on a very different, range. And this is where maybe depression, anxiety, these kind of things start to pop up. And so I would say that that's kind of how I just tailor those little things. So the principles are the same. It's just adding these little nuances to the different age groups.
I love that. And, I think about your training in substance use too, and just, right. That's what you said,
Yep.
right?
Yep.
I was like, I didn't make that up, I don't think. But your training in substance use and how some of those maybe external manifestations of some of the things that have happened to kids begin to come out in a different way than they might in early childhood. And that might require maybe a different set of partners and friends, right? Out in the community who you can refer kids to. We actually had a really good conversation with a local organization for this same grant on trauma informed care, a local group called Immerse that works with older adolescent or older youth and adolescents and young adults to help support them who may not have a safe, stable, nurturing environment in their home, and they become that for those youth. And I think it's really helpful. They help them with whatever it is they need, and they're a great referral partner out in the community here in Arkansas and in Central Arkansas for a lot of our members. They even work with trainees. They let trainees, the residents at Arkansas Children's will come over and visit with them and shadow them and learn a little bit more about what they do. So I don't know if you want to talk any more about some of those, the different partners that you might have at the different ages who might be out there in addition to what you're working with in your office.
Absolutely. I think you brought up the substance use issue for the older
Yeah,
adolescents and
yeah.
adults. It is a problem. And
Mhm.
what I found is that we don't have enough providers that feel comfortable, right? Providing that next level of care for someone who might be using to cope with whatever traumatic experiences they have been, right? And so the way that I kind of think about it is if I'm not me, right? And I need some specialist or expert or something like
Right.
that. SAMHSA actually has a great sort of findtreatment.gov website that I refer a lot of people to. So like if you're out in the community, you're in rural Arkansas, right? And you're like, there's no way there's any provider that provides, you know, treatment for opioid use disorder for my kiddos, right? Or helps them with contingency management for marijuana use, and
Right.
stuff like that. I go to that website and put in my zip code or put in my city, and I'm like, I'm looking for a provider that takes care of like this age group, and this is the problem I'm looking for. So I think I do rely sometimes on sort of these national databases that might help. They do have some, other than substance use, they do have mental health
Okay. Good.
like referral centers too. So if you're kind of struggling and trying to find a treatment center, that might be somewhere to look at. And so and then if there's sort of like consultative like phone provider lines that are in different states.
We
So
have that.
you have one. Okay, perfect. Because Maryland
Yes.
has one.
It's called ARMAP, and it's the our pediatric mental health care access program. Is that what you're? So yeah,
Yes.
so like a
Yes.
pediatrician can talk to a psychiatrist or a psychologist about a specific patient to help provide kind of guidance on how you might treat them in the medical home.
Yes. So we
Yeah,
have a similar one in Maryland, and I find that to be super helpful.
yeah.
So,
Ours
let's
is
say like
still really new, but it's great. So
that's fabulous. No, it's one of those things where like, okay, I'm comfortable. Maybe I'm feeling comfortable just doing Prozac, right?
mhm.
And I feel comfortable. That's the one SSRI I feel good about. But my kid is not just meeting where we need to be, right? Call that line up, say, hey, this situation I've got going on. What would you do next? And they're super helpful. They want to educate people, right? And so sometimes they're like, okay, well, let's just try the next SSRI. Or have you thought about doing an adjunct with XYZ? And so I do find it's okay if you're in a rural practice. It's okay, or even if you're in a more urban practice and you just don't have the resources in maybe a private practice setting. That's okay. I think relying on some of those external sites are super helpful.
Yes, I have really loved in Arkansas some of the things that we've been working on to help support the pediatrician. We've worked on getting reimbursement for healthy steps in pediatric primary care settings. So pediatricians who are part of the patient-centered medical home program can get a supplemental reimbursement through their per member per month payment from Medicaid if they implement healthy steps. We have 7 sites now with a good chunk coming on this summer too. So we're very excited about that in Arkansas and are working with lots of great partners to do that. But then also we've done a lot of work as a chapter advocating for integrated behavioral health to be reimbursed by. So if a pediatric practice would like to employ an LCSW, for example, a therapist that can bill, that they can do that under the pediatric practice instead of as an external partner, and really have that true integration of care in one site for that family, where a place where they trust the people and it might be a little easier handoff or a warmer handoff than handing off to an outside organization. So we've been really trying to help with getting some of those tools on board, and then also just promoting that mental health care access program to our members too, because it's, like I said, it's new. But I know we're coming up on time before we wrap up. What else would you like to share with our members as they think about adding trauma-informed care principles into their work and their day-to-day?
Yeah, I think the thing that I would want to leave like listeners with at the end is that we can do this, right? Like I really do think we can do this. It seems a little bit like scary at first because maybe you don't feel comfortable sort of getting all of the, if you screen something, you want to do something about it. That's just the nature of being a pediatrician, right? I heard something, I need to do something about this, right? And fix this. And I think with trauma informed care, it's just kind of coming to the visits, it's coming to understand patients just in a different lens. So, and it helps you also not take things so personal, right? So if you have a patient and the situation is escalating, if you take the trauma informed care principles to heart, you can de-escalate that situation by just understanding that, something may be going on that I just don't know about yet. And it's okay if you don't find out that one day, but just having that awareness it goes such a long way. And just really taking that genuine interest in your patients. Like I usually will a lot of my patients have like their nails done, and they're so proud of it, right? And so even if you're like, using a computer and typing notes during your visit, while you're signing on, waiting for things to load, that's the great time, right? To connect with your patient and show them that there's this genuine interest in them. And it takes literally 5 seconds because you're trying to do something else. So
Right.
I'm always like, wow, I like your nails today, or maybe their hair color is different, right?
Yeah.
Hey, your pink hair is really cool. When did you decide to do that? And I think that that just breaks down this and shows that we are human beings, and despite, all of the years of education we've done, we still are human beings. And when you break it down like that, that is part of trauma-informed care. It's being relational, not only with the caregiver, but with the patient.
I love it. I love it. Thank you so much for sharing with us today. We are so glad. This was Dr. Camille Broussard joining us to talk about trauma-informed care. And I will just also note we are grateful to the American Academy of Pediatrics for their grant that has allowed us to kind of get this podcast launched and started, and to you for being one of our first handful of guests. So thanks again, Dr. Broussard. We hope to connect with you again soon.
Awesome. Thank you so much for having me today.
Thanks.